Hi, welcome to a new edition of the ASG Guidelines. And today we're going to be talking about the ASG guideline of the role of a therapeutic endoscopic ultrasound in the management of the biliary tract disorders. And I am happy to be joined by my colleagues from the Standards of Practice Committee who led this guideline, which is coming out in GIE. And thank you guys for being here and for your hard work on this guideline. And this guideline is the first guideline in the US to discuss these options for endoscopic ultrasound for biliary drainage. So we're very excited about it. And it can be a little bit dense because of all of the acronyms. So we'll try to make it as simple as possible. We have five clinical questions that we're going to discuss, and we'll start with the first two questions. And probably the most common question, a clinical scenario, you go in to do an ERCP, but you fail for various reasons. Could be failed cannulation, maybe a mass that is difficult to get cannulation through, or you just failed the cannulation at the ampulla. And this could be for benign or malignant indications. And the question at that time is, what do you do next? Do you go ahead and wake the patient up and send them to interventional radiology, or having consented the patient in advance for a possible endoscopic approach, would you pursue an EUS guided biliary drainage approach? And do you want to tell us what exactly we found and how do we proceed with this patient?
Yeah, sure. So this is a scenario that does come up. So we found that there were similar rates of success, technical and clinical success for IR and for EUS. Where there was a difference was with adverse events. So in patients who were receiving IR guided interventions, higher rates of bleeding, higher rates of needing a reintervention that was unplanned because either the drain falls out or the drain becomes kinked and patients get recurrent infections. So we found that EUS was superior to IR, but we found that the evidence wasn't as strong. The strength of the quality of the evidence was low, so we made a conditional recommendation. So we are suggesting that we perform EUS in the situation you described. The decision about what specific technique to apply, again, depends on the patient's anatomy and your level of suspicion that the patient has benign or malignant disease. And we have a nice flow chart in the first figure of the paper that kind of outlines it for you, but just a high level summary. If somebody has benign disease, and the reason you can't cannulate is maybe severe diverticulosis of the duodenum, or you simply cannot find the major papilla, an EUS guided rendezvous is what we're suggesting you perform over IR. If the rendezvous, for whatever reason, fails, then we suggest you can either perform a choledochoduodenostomy, hepatogastrostomy, which are transmural drainage techniques with EUS, or you go to IR. And let's move to the other scenario. So now moving from benign to malignant. So let's say you can't access the major papilla because there's an ampullary mass that's distorting your access to the biliary orifice, or there's a gastric outlet obstruction, either at the level of the pylorus or the duodenum. What could you perform? There, we recommend transmural drainage with EUS. So that would be, again, choledochoduodenostomy or hepatogastrostomy, again, over percutaneous drainage.
Excellent. So again, to reiterate, the big distinction is benign diseases. We're suggesting rendezvous, and if it's for malignant indication, we're suggesting the other approaches, which we're going to discuss next. So, staying with the same patient. Second clinical question is you decide that this is a malignant disease, and you want to use endoscopic guided approach. What are the two options, and how do you go about choosing which one you should try?
So the two options we described in our guideline is choledochoduodenostomy or a hepatogastrostomy, techniques that have been applied all over the world. Different populations tend to use one technique more than the other. In our study, we found that there was really no major differences in terms of technical success, clinical success, or adverse events if you underwent a choledochoduodenostomy or hepatogastrostomy. There are preferences based again on location, what devices are available to you. For choledochoduodenostomy, there are some single-step options where you can gain access to the biliary tree and then immediately deploy a stent, whereas with hepatogastrostomy, it can sometimes take multiple steps. But again, there may be emerging devices that will soon convert hepatogastrostomy to also being a single-step deployment system. But it really, again, comes down to anatomy and other patient characteristics about which technique to choose. So if somebody was to have duodenal involvement of their cancer, You likely would not want to perform a choledochoduodenostomy due to concerns of poor healing of the stent in that tract. Similarly, if somebody has a gastric outlet obstruction that is affecting the stomach lumen itself, a hepatogastrostomy may not be preferable. But also, the level of where the malignant biliary obstruction is occurring is also very important. So, distal malignant biliary obstruction, both choledochoduodenoscopy and hepatogastrostomy are reasonable. If somebody was to, let's say, have a perihilar cholangiocarcinoma, so much more proximal, choledochoduodenoscopy likely doesn't make as much sense in that situation, and that's where hepatogastrostomy may be preferable.
Excellent. So basically, based on where the mass is, what the anatomy is, if you can get to the common bile duct from the duodenum and there's no masses in the area and it's dilated,
Yes.
then that would be probably the easiest option to perform. But if you cannot, then the hepatogastrostomy approach is excellent. All right, so those are, I think, new recommendations. Obviously, all our recommendations are based on clinical availability and expertise. We're not suggesting that patients should be transferred outside of the hospital to have these procedures done at a tertiary care center, but those are options that are available at many tertiary care centers, and they are now suggested by our guidelines. Excellent. So moving on to a different population with Nikhil here. So we talked about patients who have normal anatomy but failed the RCP for various reasons or unable to do the ERCP. What about patients who have altered anatomy? And specifically on the first clinical question, somebody that we see a lot of, patients have Roux-en-Y gastric bypass, history of gastric bypass in the past, mostly for weight loss. And the patient now comes in, they may have stones, they may have masses. And what options do we have and what did we find?
Thanks, Bashar. This used to be a real clinical challenge for most biliary endoscopists. You find someone has a stone, and then they happen to have a gastric bypass. And the main question has been, how do you reach the ampulla, and how do you effectively deliver the interventions we're used to delivering? We looked at three separate types of ways to do that. One is an enteroscopy, typically a double balloon enteroscopy assisted ERCP, laparoscopic assisted ERCP, where a surgeon gives you access to the occluded stomach, and the edge procedure, where EUS is used to connect the two stomachs to facilitate ERCP. What we found very clearly was with enteroscopy assisted ERCP, there were low rates of technical success and clinical success, primarily due to low rates of reaching the ampulla. And then, even if you reach it, not having the tools we normally do for ERCP, and the position of the ampulla being different, making cannulation challenging and delivering things like stents challenging. So, this was not a preferred option because of these lower rates. In terms of the other two choices, laparoscopic assisted and the edge procedure, they had similar rates of clinical and technical success, but the edge procedure had significantly lower procedure times. Based on this, what we suggested was that we kind of personalize it based on what the patient wants and what the clinical situation is. For example, in a patient with malignant disease or a patient where recurrent stenting may be needed, such as a liver transplant patient, the edge procedure may be preferred because you have internal access and can do multiple ERCPs as needed. However, if there's a patient who's going to go undergo surgery anyway, for example, they need a laparoscopic cholecystectomy, then the laparoscopic assisted ERC approach may be considered. I think it also has to be individualized based on the institution. In certain institutions, it may be quite challenging to do an ERCP in the operating room, or it may take a significant amount of time and resources. Also, in certain patients, they may have adhesions or other reasons why facilitating surgical access to the stomach is not easy. And so these are factors that we consider in making this decision. But what I think our guideline demonstrated is Edge is an evolving, option for these patients and can facilitate ERCP and make ERCP quite successful in these patients.
Excellent. And I would also point out that, again, these techniques are evolving and we are getting better and better at doing these. If you are good in using endoscopic ultrasound, you've done a lot of lumen-opposing metal stents, learning how to do this technique would be an extension of that. And there are studies showing that you need to do 20 to 40 to become very proficient at doing these. So certainly, we encourage, based on our guidelines, our endoscopists and advanced endoscopists to learn these techniques and to gain mastery of these skills because they can save the day for a lot of these patients. Instead of having to go to the OR, you can do it right there in the endoscopy. Excellent. So the other kind of altered anatomy is patients who have altered anatomy, so you cannot get to the ampulla, but they don't have a gastric bypass. What about these patients, and what should we do?
Yeah, thanks, Bashar. I think this is kind of a catch-all for a variety of different surgically altered anatomies, and I think I say that because it really depends on what exactly the anatomy they have is. For example, in a classic Whipple patient with a relatively short afferent limb, we may be able to reach the biliary orifice much easier than in a patient with an 80 centimeter long root limb. So I think one key principle for all these patients is just understanding the anatomy, understanding the operative report, and understanding how far is the biliary anastomosis and how do we reach it. Based on our review, what we found is that enteroscopy assisted or pediatric colonoscope assisted ERCP can be successful and had a lower rate of adverse events compared to more successful techniques such as endoscopic ultrasound guided techniques. So we suggested its usage to begin with. If you think you can reach the biliary orifice, try first with a pediatric colonoscope or say with a single balloon enteroscope. See if you can cannulate and deliver the interventions needed. If you are unsuccessful, that's where, based on technical expertise, the patient's anatomy, you could consider EUS guided access of the bile ducts. I think compared to the previous questions where we can kind of neatly delineate it into like colonoduodenoscopy or hepatogastroscopy, in this case, it's going to be individualized and personalized in terms of how you access the bile ducts and what interventions you deliver. But typically, it involves accessing the bile ducts through the liver, the stomach, or hepatogastroscopy for access, and then delivering interventions such as removing stones or placing a stent, etc. That's kind of our suggestion that you start with enteroscopy assisted or colonoscope assisted first. If it fails, consider EOS guided drainage techniques, but individualize that decision with the patient.
Excellent. I think out of all the interventions we're talking about today, probably gaining hepatogastroscopy requires more technical skills and expertise. Very good. So we've talked about these patients with normal anatomy, cannot get in, altered anatomy, gastric bypass, non-gastric bypass. Last but not least is a very important clinical question that we see very often, which are patients who come in for acute cholecystitis and they are not surgical candidates for any number of comorbidities that they may have. In the past, we used to maybe send these patients, we send all of them to IR to place a percutaneous drain, which can be painful and not very preferable for many of our patients. Now we have different endoscopic guided approaches that we want to look at. So, Swati, what did we find out about US guided gallbladder drainage?
Sure. So when we compared in our systematic review and meta-analysis, when we compared patients who had PT-guided gallbladder drainage with EUS guided gallbladder drainage, we divided it into two kinds. I'll begin with the subgroup analysis first, where we just used those studies which use LAMS or lumen opposing metal stent for gallbladder drainage and compared that with percutaneous drainage. And we found that there was no difference between the two studies when you compared technical success, clinical success, 30-day mortality, overall mortality, and rates of recurrent cholecystitis. What we did find, however, was that the group which had LAMS had reduced adverse effects, which was significant, reduced reinterventions, reduced readmissions, and future need for cholecystectomy. When we compared all our studies, which were about 5 studies, 1 RCT, 4 observational studies, we found that the technical success was significantly lower in the EUS gallbladder group. But again, that was all stent comers, be it plastic or metal or lumen opposing metal stents. So I think what we had moderate level of evidence because of a RCT that was involved in this analysis, but we did take into account the local expertise, knowing that percutaneous drainage is more widely available than the expert centers which can provide the US gallbladder drainage. So again, like my colleague said, personalize it to what's available. You could go with either percutaneous or US.
Last but not least, we are going to talk about a very common clinical scenario in which somebody presents with acute cholecystitis, but they're not a surgical candidate for many different reasons or comorbidities. And the question is, can you use US guided approaches to drain the gallbladder instead of sending the patient for percutaneous drainage? So, what did we find about that, Swati?
Sure. So in our systematic review and meta-analysis, we did a subgroup analysis of 3 studies, one of which was an RCT. We had 143 patients in the EUS LAMS group and 144 in the percutaneous group, and we found that in those patients which were drained by lumen opposing metal stents, they were associated with reduced adverse events, which reached statistical significance, We also noted reduced reinterventions, readmissions, and reduced need for cholecystectomy. The technical success, the clinical success, the rates of recurrent cholecystitis, adverse events, and overall mortality remained the same. Now, having said that, our main analysis was based on 5 studies, but that included all comers. So, plastic stents were put in the gallbladder, metal stents, as well as lumen opposing metal stents. And in that analysis, we did notice that the technical success in the EUS gallbladder group was significantly lower than the percutaneous group. So nowadays, with all of us doing LAMS or using LAMS for gallbladder drainage, we could safely go with either or. And again, based on what my colleague said, it'll depend on personal expertise or expert expertise in the expert availability in that particular case scenario. So we could go either with percutaneous or we could go with the US. Now, having said that, there are certain clinical situations where you might want to go with percutaneous gallbladder drainage, and those would be perforated cholecystitis, unable to tolerate sedation, or biliary peritonitis. On the flip side, if there is inability to access the ampulla, the patients can tolerate sedation, there's no perforation, and there's significant cholelithiasis, EUS guided gallbladder approach might be the better option.
All right, excellent. Staying in the same line of questioning, the patient comes in, should you do a transpapillary approach, which we've used that for a longer time than EUS guided approach?
Yes.
And what are the benefits, advantages, disadvantages, and which one should be considered first?
Sure. So in our, again, going back to our systematic review and meta-analysis, we had 3 observational studies only in this area. We had 148 patients in the EUS group. We had 163 patients in the transcystic transpapillary drainage group, and we realized that EUS guided gallbladder drainage was better with or superior in terms of clinical success, technical success, as well as recurrent cholecystitis. It also obviously had lesser of post-procedure pancreatitis because there was no ERCP involved. Both of them showed no difference when it came to 30-day mortality, adverse events, otherwise a reintervention or future need for cholecystectomy. So again, we prefer the EUS guided gallbladder drainage in this group just because it's difficult to cannulate the cystic duct based on its anatomy. But in patients who have ascites, severe ascites, who are coagulopathic, who are getting an ERCP because of a CBD stone or otherwise, or are a potential candidate for surgery, or our liver transplant candidates, we would prefer going the transcystic route, transpapillary drainage, as opposed to gallbladder drainage.
So basically, if you're doing an ERCP anyway,
Yes.
if you need it because of choledocholithiasis,
Yes.
maybe the patient had a history of ERCP and it may be easy to cannulate, then
Yes.
maybe consider doing the ERCP approach.
Yes.
It's also very challenging to do because the cystic duct is tortuous,
Yes.
and cannulating the cystic duct is not always as
That's
easy to do once you get a wire across. So in these cases, I think EOS guided would be very beneficial. I want to again thank you guys so much for working very hard in this guideline. Like I always say, these guidelines take about 1 or 2 years of our lives of intense literature review and synthesis and presentation and drafting. And we hope that these will lead to better patient outcomes. All our guidelines are based on the best available evidence. We thank you so much for watching us, and thank you guys again. Have a
Thank
great
you
day.
for the opportunity. Bye.
Thank you.